Really, it's a great pleasure to be with you, and thanks for the organizer and SSBMT, as well as the EBMT. And it's also a pleasure to talk about, switching gears to hemoglobinopathy. This talk, actually, it's a combination talk. It was presented in the last EBMT about conditioning regimen for TDT patients. Part of the EBMT hemoglobinopathy party. So today we'll go through an overview, so some introductions and the factors contributing to TDT outcome conditioning for match-related donor and alternative donor transplants, and then finally we'll try to have some conclusions. It is very tricky subject because every center do their own conditioning regimen and their own recipe. But this also, so I'm going to try to go at the beginning, talk about the historical part of that. My disclosure. And this actually slide comes from the EBMT working party, and it stops at 2020. You see the COVID time where a lot of shutdown happened for the elective transplants. But if you look at the trends, you see in hemoglobinopathy that sickle cell keep going and rising in transplants. But for thalassemia, it's sort of plateauing, at least in the children. And you see also that in the adult population, the number of transplant is much lower, and that's expected because of the fitness of the patient and the organ function over time. If we look at the general outcome, general two-year-old survival, it was in the 92% and the 80s for the thalassemia patient. But what makes transfusion-dependent thalassemia patient challenging is their massive pre-transplantation exposure to blood products, expanded erythropoietic marrow, no prior chemotherapy exposure. Their marrow is very active. And also, of course, the iron overload and the organ function has a possible implication on the outcome. Plus minus the organomegaly or splenomegaly as part of the. This is the CIBMTR data that looked at the around 1,100 patients of TDT patients who received transplantation, and based on donor type, you'll see different outcomes. We have to keep in mind here that this data is published in 2019, but it's lagging a little bit behind as we're talking today, especially when we talk about the mismatch related or haploidentical outcome. If you look, for example, on the EFS, it will be going around the 70% range. But it's clearly here, it's been a standard of care in match-related donor transplantation with an excellent outcome if you transplant them early in childhood. Similarly, the match-unrelated donor is a good choice if you identify them earlier. Now, that might be a little bit different in different parts of the world because having a match and unrelated is a bit of a struggle in certain areas around the world. But having a match-related donor also is something that also variable. And for example, recently we had with our colleagues in the adult check, and around 60% of the Saudi population have around matched family donor. And that also opened the area because of high rates of consanguinity, and people may get into finding a donor much easier, even in the extended family sometimes. How about the age effect on the outcome of TDT patients? Those are very important points before going to conditioning regimen, but it's clearly shown that older the age, the lower the outcome, but in transfusion-dependent thalassemia. But really the curve goes down dramatically above the age of 15. So if you are less than 15 years of age, you have a reasonable outcome. Of course, the best if you are less than 6 years of age. So you're talking about 90 plus outcome going down to the 70s and 65. How about the organ function and the classic representation of iron overload? Pissarro and Lucarelli group have already looked at over many, many years, and the patients were identified based on the presence of hepatomegaly, liver fibrosis, and the irregularity of chelation therapy. And although this is kind of a bit debatable in the adult population, but in the pediatric, based on this scoring system, class 1 will have a much better outcome compared to class 3, where they will have a lot of iron overload and organ dysfunction. So in summary, all those three main factors plays a role, and you see it clear by putting the age, an adult. If you look class 3 and adult together, you'll go to 65% range. So that's the big challenge, actually. And this similarly could be replicated in the unrelated transplantation and the haplotransplant. So the question comes to all the time, what type of conditioning regimens we should use. And this is always the standard of care versus all the trials, and how can patient tolerate reduced intensity or something in between, like reduced toxicity. So one of the things that also has definition, and I would discuss it here and then we'll come to it during the presentation, is what's called the pre-transplantation immunosuppression that can minimize the mixed chimerism and graft failure in high-risk patient transplants. And this approach has been taken by different groups around the world with different approaches, whether in Italy or in Asian countries or India. So one of the options will be hydroxyurea as a thioprin and hypertransfusions. Other groups have been doing fludarabine, cyclophosphamide, and dexamethasone as a pre-transplantation immunosuppressive therapy, and some will give fludarabine and dexamethasone. So now we'll go through historical informations, and we'll go through the type of conditioning regimen in match-related donor transplantation. So I will start going down back to the 80s and the 90s. If you look, and I try to highlight in red the biggest studies and outcomes. And of course, it comes back, of course, to Lucarelli et al., late 90s and in the 2000s. And if you look at the beginning, so the first one with a large group was 116 patients. That conditioning classically was a BUSI. And if you look at the class 1 and class 2, class 3 definition, you will find the class 1, 94% will do the great job, best outcome. But if you go down to class 3, you will find 61 and 53%. So that's a very challenging thing. So later on, and in the following 10 years, the 393 patients of class 1 and 2 continue to do well with BUSI. However, class 3, there have been some reduction in the cyclophosphamide dose, and that led to some improvement compared to the initial outcome. Later on, ATG was added and by groups, and that could also improve in the outcome. But also other protocols have been emerging in the 2000 era. And one of the big ones, if you look at the table, will be Bernardo et al., where, of course, people will be manipulating and adding thiotepa as an immunosuppressive agent as well, and it has a very good effect. So with this outcome, it was in 2008 around 20 patients, but they've got treosulfan instead of busulfan, thiotepa with fludarabine and ATG. And the outcome included both matched family donor and matched unrelated donor, and they were in the ranging in 95% survival and 85% event-free survival. So those are great outcomes that have been evolving with time. Other groups also have been using other approaches, such as the use of Protocol 26, which I will come to in Italy as well, with a great outcome. Now, if we look further into the number of patients enrolled in the following years, you'll see some area around the world continue on the BUSI, replicating the Italian outcome. So ranges the outcome between 80 to 70. But it was also interesting because some of the group also have started the pre-transplantation immunosuppressive approach. And that you could see by the group, for example, Lee et al. For 30 patients. And they've given those patients hydroxyurea and azathioprine and hypertransfusion, and then followed by the myeloablative regimen here, and in other ones will be reduced intensity. Now, late in 2012, Bernardo et al. Have, the group have already published their 60 patients, similarly with the excellent outcome, 93% as an overall survival and 84% as the thalassemia-free survival. Now, just to catch up on, I'm just highlighting the difference. Many groups continue to do the same, different part of the ward, but I will highlight the Gaziv et al. Approach, which is they've done the newer approach with 16 patients with this protocol 26, which I'll come to. Compared to the classic BUSI Thiotepa, and the outcome was really amazing by the group. So what they've done actually is to give pre-transplantation fludarabine and hydroxyurea and hypertransfusion, and then a BU Thiotepa with Cy and ATG. The outcome was very acceptable, and actually it's a change. So many people in the world in the Asian group have adopted a sort of similar approach with modification. And here I would like to highlight the group from Thailand, where they have used the flu-BU ATG only, but before that giving a long course of pre-transplantation immunosuppression, and particularly talking about dexamethasone and fludarabine at day -60. And what's interesting in this group, the median age was 17. So it means they are older patients. And also the outcome is in the 90 and 93% as published by the Italian group. This group have continued to publish later on. I'll mention that in the haplotransplantation as well. In terms of local data in the Middle East, there are multiple studies coming from Jordan, from Saudi Arabia. Dr. Jeffrey have published the 160 patients with the outcome of 90% for a match-related donor overall, and the thalassemia-free is 77%. However, if the outcome is extremely better, I mean, looking at class 3 is lower, but when BUSI and fludarabine was used as the evolution of the Italian group, their outcome was also amazing in the 90s. In our center, we did around 48 patients, the initial ones with BUSI ATG, but the last 36 patients, Thiotepa BU flu was the main approach with an outcome of 97% and a 94% of event-free survival. One thing to point here, it's mainly class 1 and 2 and less of class 3. And finally, the EBMT showed that in a big study that a BU-based, TREO-based is really acceptable, excellent outcome, although we know with treosulfan there is some sort of more mixed chimerism, but this also have already been negated with different approaches by different groups. So how about match unrelated donors? So I'm not going to spend a lot of time in unrelated donor, except that, as we know, the risk of GVHD is higher. And that has been clearly shown in early studies in the 2000 era. And most of the study comes from Italy, from Lanasa et al. And if you look at the regimens, it took exactly the similar approach as match-related donor, but the addition of serotherapy and the outcome of GVHD was a little bit different. Now, if you look here, it was lower, like the event-free survival were in the 70s, in the early 2005, 2000 2007. Bernardo et al., similar to what's match-related, they included the match-unrelated with an excellent outcome for 60 patients, which were divided between match-related and match-unrelated donor. Now, if you look at other approaches as well, as I mentioned earlier, similar, the Thai group also have used their regimen both in related and unrelated and in haploidentical transplantation, but the difference is in haplo they added post-transplant cyclophosphamide, and their outcome is in the 90s. And these are also similar outcomes. People are using trio-based regimen and or the Thai group. 4 patients come from the Indian group. They use the same, almost the same approach as the Thai group, and with an excellent outcome. So how about alternative donor? And here is the big challenge, because before we were talking about nowadays outcome above 80s and 90s, but now when you go to haploidentical transplantation or cord blood, we have to focus on 2 things. For cord blood, let's just finish it quick. It has been really disappointing in the cord blood that in TDT patients for unrelated cord blood outcome is not as great as the others. And one of the big referred studies by Ruggieri et al., about 35 patients, you look overall survival 60%, and a lot of graft failure and event-free survival is lower. The only study that showed a high number of good outcome is by Jane et al., and they used Bucy-ATG, but the difference is double cord blood has been used. And in this category of patients, in this study, it showed that the GVHD rate also was very, very high. So it was a high-dose cord blood with double cords. If we look at haploidentical transplantation, early in the 2000s, the multiple group have done multiple things. In Europe, it's mainly the approach with the ex vivo T cell depletion, as opposed to the PTCY approach in some other countries. The initial studies have tried to put the number of patients above 20. Sudani et al. Was the biggest cohort using this approach, but around 28% of the patient had graft failure. Although the outcome is 93% overall survival, 71% was the thalassemia-free survival. So that was an issue. Despite doing pre-transplantation immunosuppression with hydroxyurea as a thioprin and giving a good condition regimen, the graft failure rate was a bit higher. On the other hand, the other groups in Thailand have already looked at the studies using their same approach plus PTCY. And it's very interesting that their outcome is very promising. On the other side, if you look at Prof. De La Fonte and his group in the UK and with a collaboration with the US, they've done hydroxyurea as a thioprin plus hypertransfusion, and a regimen similar to what's used in the Vanderbilt group in the sickle cell, been using ATG, thiotipaflucide, TBI between 200 and 400. The approach was in the 80s, and that was also encouraging initial outcome. How about lately in the last 2 years? Merli et al. Have, from the Italian group, have done in non-malignant diseases, Bu-Flu thiotypa regimen with a ex vivo T cell depletion, alpha-beta depletion. But out of those 70 patients, 10 patients were TDT. What's mentioned in the abstract, mainly thalassemia, remains a challenge. The overall survival is 91%, but the event-free survival was 60%. Now, the Thai group with 83% have currently the best results in the literature using their approach. But also, if we dig deep into the studies, they were still having some infections, hemorrhagic cystitis based on their approach. Replicating other studies, Jaswal et al. From India have done 5 patients out of 10 hemoglobinopathy using Triaflu, MEL, and PTCY, plus using abatacept after post-transplant cyclophosphamide to decrease the GVHD, also have some promising results, some early results. Our colleagues in the adult, Dr. Mohsen Zahrani, have done 4 haplo patients out of 7 with this approach, with PTCY, the Vanderbilt approach, and the outcome is around 86% with 71% thalassemia-free. And finally, actually, a month ago, the German group have published their 20 patients. 13 of them were haploidentical transplantation using the trio Thiotype flu approach, but again using the TCR alpha-beta depletion. And the outcome is amazingly excellent, and then with the haplo 92% as thalassemia-free. Now, I must say the GVHD, acute GVHD, was around 38%, but they were all mild, less than grade 3.
3 minutes, Dr. Mohammed.
Sure. So the coming 3 or 4 slide is just mainly to give you an idea about this concept of the pre-transplantation and what the Thai group is doing. So they start the early phase with dexamethasone fludarabine at day minus 68 for 5 days. And in between, if the patient has alloimmunization, they keep, and there was a great talk yesterday for DSA and anti-DSA, with using bortezomib, rituximab as a sort of desensitizing the patients, and then follow with another block between minus 40 and minus 36. It's a bit extensive kind of workup, but later on you'll get ATG BU flu regimen, followed that by the PTCY. On the other hand, part of the evolution of the haplo, this is what have been also discussed by Prof. De La Fonte and his group, hypertransfusion and hydroxyurea with the conditioning regimen with a PTCY approach. And finally, this is the Jaswal et al. Have described the use of abatacept after with PTCY as a GVHD prevention technique. I'll refer you to this also very recent publication in the TCT in 2025, where they have also put the Chinese group outcome. And in this meta-analysis or the review, it was favoring myeloablative over the REC and PTIS pre. However, all these outcomes have been looked at. We need to look at it carefully, as both approaches are acceptable depending on center experience. So in summary, this is the evolution of conditioning regimen in TDT patients. It started initially in the 80s with the Bucy. Thiotype was added, then ATG. People have been using treosulfan versus busulfan adjusted dose based on levels. And nowadays, people are having another approaches in the haploidentical transplantation, particularly using the pre-transplant immunosuppression approach. So this will put us in a conclusion that conditioning regimen remains different and very variable between different centers around the world. Although myeloablative conditioning in the pediatric group is well tolerated and very well done, many centers have moved to treosulfan, fludarabine, thiotype, and ATG versus busulfan with monitoring level. All seems to be appropriate regimens. The pre-transplantation immunosuppression followed by reduced intensity is a promising approach, especially when we talk about class 3 patients or adult patients. Minding in mind that here we're not talking about gene therapy approaches, which is another approach in some patients, but myeloablative remains a major issue in both approaches. GVHD remains an issue in unrelated transplantation. However, evolution of GVHD treatment and prophylaxis also is something that's also evolving, and routine use of other techniques in the ex vivo depletion and abatacept. Haploidentical transplantation protocols are evolving with both approaches are acceptable at the moment with promising results and with hopefully in the future better outcome and better approaches will be open for our children and patients with thalassemia. With that, I would like to acknowledge the EBMT Hemoglobinopathy Working Party, of course, all hemoglobinopathy patients around the world and all centers contributing, and to our stem cell transplant team, the pediatric and the adult at King Abdulaziz Medical City in National Guard, Riyadh.